thrilled to be joined now by an old friend and a colleague, Dr. Blase Carabello. Blase, as you all know, has been really a pioneer in hemodynamics of valvular heart disease and keeps those of us in the echo world straight. So, Blase, thanks for joining me.
My pleasure, Andy.
The concept of low gradient severe AS, what is it and how do we treat it?
So there are two varieties, and I think the treatment is still up in the air. In the first case, the LV has become so disabled from damage done to it by persistent pressure overload that it no longer can generate a stroke volume. It can't generate a stroke volume. It can't generate a gradient. And these folks have had a much worse prognosis than the average patient with aortic stenosis.
But you say it's so disabled. Is it visually, if you look at it on an echo?
Ejection fraction would be 20%.
Okay, so we're talking about bad LV.
Bad LV.
Okay.
And unlike the typical patient with aortic stenosis that may have reduced ejection fraction but has a 80 millimeter gradient, you fix those guys, the next day their ejection fraction is 50% because you've unloaded the ventricle. Here, think about it, if you've only got a 20 millimeter gradient, how much unloading can the surgeon really do? And so the results have been much worse, operative risk being anywhere from 10 to 30%. 3-year, 50% survivorship. So it's a tough, it is a difficult situation, but it's not hopeless.
Okay, I'll come back to that. So how do we know that the ventricle is bad? Are these the ones that we do a dobutamine challenge on? Or?
That's where you start. So that if they demonstrate inotropic reserve by increasing stroke volume by 20% with infusion of dobutamine, their operative risk is reasonable. It's about 10%.
Okay.
My guess is it's the inotropic reserve that helps them get through the operation.
Right.
The difficulty is that even if they don't have inotropic reserve, some of those folks still get better, and we don't know who they are.
Do we look on MRIs, gadolinium? Do we do strain? What do we do?
Well, I think there's some evidence that that in terms of MR, if they've got a lot of fibrosis, Carabello's rule that dead meat don't beat. If there's a lot of damaged tissue, or if they've had multiple myocardial infarctions from coronary disease, and that's why the ventricle is no longer working well, they're not going to recover probably.
Okay, second type, so the type that's got low gradient but good EF.
Now they have such terrific hypertrophy. The walls of the ventricle have become so thickened that there's no room for the blood. End diastolic volume is decreased, and even if you're ejecting 70% of a small number, let's say the end diastolic volume is 60, well, 70% ejection fraction, EF looks great, but that's only a 42 cc stroke volume, which again doesn't make much of a gradient. And the problem is, as one of the writers of the guidelines, we indicated that a gradient of 40 was important in defining severe AS. The fact of the matter is these folks can't make a gradient of 40. There's not enough blood in the ventricle. But if they are symptomatic, they have symptomatic severe aortic stenosis, and if you ignore them, they will die. And so that's the issue, is the clinician has to be aware of this group and not say, oh, well, the gradient's only 25. They can't have severe AS, and therefore I won't refer them for an aortic valve replacement.
Typical profile of those patients, is it older women, small women?
Typically, if you look at who has this exuberant hypertrophy, it's typically older women, and I don't think John Carroll described this in 1992, and I don't think to this day we have any understanding why it is the older woman that is more prone to this kind of hypertrophy. I'll bet if you look, though, they've had hypertension for a large part of their lives, and that's what's primed the pump.
Blase, of the percentage, if you took 100% severe AS, what percentage have these low gradients normal EF?
My guess is about 10 to 15%. It's just they're the ones that seem to turn up all the time because the decision-making process here is quite difficult, and the outcomes are still not great.
Do you operate on them? And if you do, you say the outcomes are not great. I mean, I'm thinking, okay, maybe let's go ahead and operate on them, but then you have to watch volume and all that stuff critically.
It sounds like a cop-out, but I think this is where you really have to engage the patient and explain to them what the risks of the operation are, what the likely outcomes are. If you have a patient that says, you know, doc, I'd rather die than live like I am now, and I say, well, there's a 70% chance you'll get better, that's a pretty good deal for that patient. The other patient that says, you know, doc, I don't know how many years I've got left, but I just assume not risk it in the OR, that's a different patient altogether.
So it's really patient discussion
to some extent, yes, because I think it's still a black box, and we know some of the guidelines or some of the parameters, and especially low gradient, less than 20. If the low gradient is due to extensive coronary disease, if they have a lot of fibrosis, and if they have no inotropic reserve, I've just defined 4 things that make that group especially at high risk.
Good, excellent point. Let me switch gears for a second and ask you one question. You've certainly been key, along with Bob and a lot of the other people in the guidelines, the 2008 guidelines. You are in the process of rewriting those guidelines. The 2008 guidelines were criticized a little bit for lack of trial evidence and all that sort of stuff. How do you all go about the process now, just briefly, to update the guidelines?
So obviously the first step will be an exhaustive review of the literature to see how new literature has impacted what we said in the past.
Right.
And the nice thing is, for once, we actually have some new literature.
We've got a lot of literature.
We have a lot of literature that's new. There has been a terrific interest in valvular heart disease, as you can see from this meeting, bolstered by some new therapeutic options that we didn't have, but still there's a lot more literature than there was, and all that will be taken into account. The evidence will be upgraded and updated, and I suspect that the next guideline that comes out will be quite a bit different, especially with regard to aortic stenosis and mitral regurgitation from where we were in 2008.
Last question. You know, you've obviously done extensive great work on the hemodynamics of valvular heart disease. That's almost a lost art, isn't it? I mean, if you think, we're talking about cath-based hemodynamics. Now it's echo Doppler based. Is that a shame that it's, that there are a lot of the young cardiologists aren't trained in hemodynamics?
Well, first of all, I give a plug. Dr. Nishimura and I are about to have in circulation an article entitled "The Cath Lab for the 21st Century," where we go through some of these things. Echo Doppler is by itself a wonderful hemodynamic tool that embraces all of the physiology that we've always looked at. And if you can get it non-invasively, that's terrific. The problem is that there may be 10% of cases where after a thorough echocardiographic examination, you're still in the weeds.
Right.
Now you need hemodynamics, and like any other tool that's practiced rarely, we don't get very good at it.
Right.
And I think it's true. Our younger physicians are not well schooled in hemodynamics. It's just a fact.
Right.
They've got so many other techniques they have to learn to be practicing cardiologists. But I think perhaps the advent of the percutaneous techniques will reintroduce the importance of hemodynamics. You don't want to send somebody off for one of these devices unless you're really sure about what you're dealing with preoperatively.
An interesting side, and I think you're exactly right, interesting sideline on that is there was a recent article about the AI index in TAVI valves looking at severity of perivalvular valvular AI, and it was all based upon hemodynamics that you'd measure in the hybrid OR and the cath lab.
Yes,
so there is life.
There is life for hemodynamics. One of the functions of the heart is to drive blood around the circulation. That's called that's called hemodynamics, and it would seem like a good thing to know if you're a cardiologist.
I'll have to look that up.
Yeah, look that up. That'd be good.
Thank you very much for joining us.
It's been my pleasure, Ray.